Welcome to Quality Time, a Houston Methodist leading medicine podcast. I'm your host, Dr. Schaal, a clinician scientist and a retina specialist, and I serve as the Chief Physician Executive of Houston Methodist, located in the world-renowned Texas Medical Center. I passionately believe that quality is the heart of healthcare, and a commitment to quality is essential for every healthcare system. Join us each month as we discuss the latest advancement in quality in healthcare with clinicians, researchers, physicians, industry experts, and thought leaders who are as passionate as I am. And today, I'm pleased to welcome Dr. Pedro Ramirez. Dr. Ramirez is the chairman of the Department of Obstetrics and Gynecology, OBGYN, at Houston Methodist. He is also the Alan L. Kaplan Chair in OBGYN. Dr. Ramirez is a prolific writer and editor. He is the editor-in-chief of the International Journal of Gynecological Cancer. He has published over 300 manuscripts in peer-reviewed journals, including the New England Journal of Medicine, and also published 19 book chapters. He is the co-editor of the textbook titled The ERAS Society Handbook for OBGYN. Dr. Ramirez is also a host of a podcast. He is the host of the International Journal of Gynecological Cancer podcast. Welcome, Dr. Ramirez. Can you please tell me a little bit about yourself?
Well, thank you so much for the invitation. It's truly an honor to be here and taking part of this podcast. And congratulations to you for hosting this podcast. As you mentioned, I'm Pedro Ramirez, and I'm a gynecologic oncologist. And I did my training here in Houston at MD Anderson. And I was at MD Anderson on faculty for 25 years. And on May of 2023, I became the chair of OBGYN here at Houston Methodist, and I'm extremely proud of that.
Fantastic. So the field of OBGYN, what does it include?
Yeah, so the field of OBGYN encompasses a number of subspecialties within the umbrella of the OBGYN. Typically, of course, obviously, it's obstetrics and general gynecology. And as part of the subspecialties are gynecologic oncology, which is my field of expertise. Then there is maternal fetal medicine, and then there's urogynecology, and then the reproductive endocrinology.
So this is a Quality Time podcast. We focused on quality. Tell me a little bit about quality in your field.
Yeah, and obviously it's extremely important because, as I mentioned, there are a number of areas that are encompassed by the field as we take care of obviously women throughout the all of the age groups, and of course for us quality is extremely important because we are a field that not only takes care of women for their daily healthcare, but also is a surgical field. So we need to be attentive to all of the outcomes and metrics that are pertinent to any patient undergoing surgery.
So in surgery, we always want to prevent infections at the site of the surgery.
Yeah.
Tell me a little bit more about how you do that here.
Yeah, that's, of course, obviously, it's a top priority for us, not only in OBGYN, but I think in all the specialties here at Houston Methodist, because it is a measure and an indicator of the quality of the care that we provide for our patients. So it is a metric that we're incredibly attentive to in our department. And to that end, we actually have recently implemented an initiative that is called the Surgical Site Infection Prevention Bundle. And that has been really a great initiative in that it encompasses multiple disciplines within the Houston Methodist system because it's not just about the input from the physicians and the surgeons, but also the nurses, the infectious disease specialists, the pharmacists. So a number of individuals really coming together to put together this bundle that will ultimately achieve better outcomes for our patients and ideally reduce the number of surgical site infections in our patients.
So this bundle, what does it include?
Yeah, so it focuses on a number of evidence-based parameters that are implemented so that we will decrease the surgical site infection, and these generally include the appropriate administration of antibiotics to assure that we strategize to maintain things like glucose control, to maintain adequate temperature in the operating room, to assure that the patients that need a bowel preparation prior to surgery have that bowel preparation as appropriately indicated in select patients that are undergoing surgery, that we provide the most sterile technique in terms of our surgical closure, and that we implement the strategy in the perioperative care of that patient to ideally reduce those infections.
And have you seen a reduction in infections?
Well, so far, we implemented it in November, and of course, obviously, it's a short time to see a difference. But and I think of course, obviously, we'll be very proud that we haven't seen a surgical site infection since the implementation of the program. But I know, of course, it's short time; it's just a few months since that implementation.
Fantastic. And this is implemented system-wide at Houston Methodist?
Not yet. I mean, I think that, certainly we would be very happy to see this implemented system-wide, but I know that there are other areas that have expressed an interest in using it. And within OBGYN, now we're actually implementing it at the regional sites as well. So I know that a site like Willowbrook, they have already looked at implementing this. In West also, they have looked at implementing our bundle. So we're really extremely proud of the fact that we initiated it here in the main campus in the medical center, but obviously, hopefully will serve the other sites and ideally the other specialties within surgery.
Fantastic. Basically, you're saying that you are standardizing the care for every patient, and you have a checklist of things that you check before surgery and make sure that you've done that. That's really the basis of quality. So congratulations for doing that. We mentioned that you are an editor of the book called ERAS. What is ERAS? Tell us a little bit about that.
Yeah, so thank you for highlighting that. ERAS stands for Enhanced Recovery After Surgery. And this is an initiative, and certainly it's not a novel initiative, but certainly is now something that is increasingly more implemented in a number of institutions. And one certainly is a quality improvement initiative that I think is really critical for all surgical services to implement. And basically what that is that it's a set number of interventions preoperatively, intraoperatively, and postoperatively that really necessitates an integrated team to achieve high levels of compliance in that implementation. But ultimately, the goal of an enhanced recovery after surgery program is not only to shorten the length of stay of the patients, to reduce the readmission rates, but it's also to reduce the complications and ultimately to improve the outcome of those patients in terms of getting those patients back to a functional daily activity much sooner than they would otherwise without this program.
So what do you do before surgery, for example?
So we look at, some of the paradigms that we have implemented for many years that often were not evidence-based. As an example, we often would tell patients, don't eat or drink anything after midnight the day before the surgery. Many patients were not ambulated immediately after the surgery. Many patients were not fed, particularly patients after they had an abdominal incision after surgery. And really, that wasn't really based on any evidence-based science. So this brought into question, what do we do to prepare that patient for surgery? What are the ideal things that we can do? And certainly, obviously, is making sure that we have the appropriate preparation for that patient, in that the patients are able to drink up to 2 hours prior to surgery. The patients are given carbohydrate loading prior to surgery to decrease the likelihood of things like surgical site infection in the post-surgical period. The patients are given the appropriate antibiotics. We make sure that we focus on glycemic control before surgery, and that we are targeting also normal thermia and adequate temperature in the patients prior to surgery. In the operating room, we try to minimize the amount of opioids that patients receive. We try to also provide medications that will limit or minimize the amount of nausea and vomiting that patients have in the immediate postoperative period. We try to use anesthesia, which is called total intravenous anesthesia, which will have a lower likelihood that the patients will have a slow recovery in the immediate postoperative period. And certainly also we target analgesia by implementing certain strategies just prior to closure of the abdomen to minimize the amount of pain that those patients have, with ultimately the goal to minimize the amount of opioids that they receive in the postoperative period. And then just highlighting among the changes in the postoperative period is that patients are fed the same day of surgery, a regular diet. Patients are able to ambulate the same day of surgery. And we put an emphasis on patients ambulating at least 8 times a day, patients being out of bed for at least 8 hours a day. So these are all elements that help the patients mobilize the patients, certainly to get back to their functional daily activities. And a lot of that has to deal with the composite efforts of a multidisciplinary team, and then also an emphasis on patient education and raising awareness about the expectations that the patient is going to have in the perioperative period.
And does it depend which surgery the patient is undergoing? Is this tailored towards the procedure?
Yeah, that's a great question. And I'm glad you asked that question because actually oftentimes we get asked, well, enhanced recovery is for the more minor procedures and not really the complex procedures. But in fact, it's quite the opposite. And we found that the enhanced recovery programs will benefit those patients that are highest risk for perioperative complications. Certainly the elderly patients, the more obese patients, the patients who are undergoing high complexity surgery. For us in gynecologic oncology, pelvic exenterations, those patients are typically the ones that will benefit the most because, implementing all of these strategies will decrease things like the surgical site infection, decrease the fluid overloading, the constant nausea, vomiting, and ideally the readmission rates.
Fantastic. And in your you're not new in this profession, right? How many years you've been in OBGYN?
Now I was 25 years, yeah, and as an oncologist at Anderson. Now my last year here, latest year here.
So a quarter of a century of experience. And have you seen the changes of how patients recover from surgeries? What is your perspective?
Yeah, absolutely. Actually, there is certainly in my professional lifetime, there's the pre-enhanced recovery and the post-enhanced recovery period because I helped implement it in my former institution at MD Anderson in 2014. I still remember, it was November 2014 when we started the program. And it was quite remarkable in terms of seeing the difference in not just the reduction in opioid consumption, opioid administration, but also seeing the functional recovery of those patients. And one could say, well, how do you measure that? Because a lot of times, to a surgeon, you ask, well, how are they doing? And they're like, oh, they're doing great, right? But we actually had objective measures through something called MEDACI, which was developed by the symptoms research team. And they look at patient-reported outcomes. And that's really important, and that's really integral now in many surgical subspecialties, evaluating the patient-reported outcomes. And briefly, what that means is that this is an evaluation of the recovery of the patient as perceived by the patient.
Wonderful.
Not as perceived by the nurses or the anesthesiologists or the doctors. Because oftentimes, for an anesthesiologist, the patient recovering is basically extubated and leaving the operating room. For the nurse in the recovery area is the patient going up to the floor. And often for the doctor, recovery is the patient went home. But often for the patient, it is about getting back to doing the things that they enjoyed most and getting back to feeling exactly how they felt before they were ill and before it was the index event that brought them to the hospital. So having the patients give you that validation, objective validation that they're doing better is one of the measures that we were able to really make a mark upon by implementing enhanced recovery.
Wonderful. And this enhanced recovery protocol, is it implemented in other specialties other than OB/GYN?
Yeah, actually, in fact, now I really can't think of any specialty where there hasn't been a publication about the implementation of enhanced recovery programs. And I think, certainly there's a lot of enthusiasm by not just the physicians and patients, but also by hospital leadership, because implementing enhanced recovery certainly has been shown to decrease the average cost of caring for that patient, because it is not just an element of the patients being discharged sooner, and of course, obviously freeing beds for subsequent patients to be able to have their appropriate care, but also the care related to that patient in terms of if the patient's not consuming opioids, the patient doesn't have a PCA pump, the patient doesn't have the nausea, vomiting, certainly the shortening time in the hospital, the lowering of the times that that nurse needs to attend to that patient to deal with all of these symptoms really impacts the overall healthcare system. And in fact, also that patient gets back to a normal functional daily activity sooner. That patient becomes a productive member of society. Those family members do not need to take time off of work to attend to the patient that just had surgery. So it has really a lot of positive ramifications. And again, I mean, I think that what's important and needs to be highlighted that when these programs are implemented, it is important to assure that there is compliance with the program. So it's not just about the saying, well, we're initiating the program or yes, we put that in place, but it's to assure that you have compliance with each of the elements of the program.
And the patient is an active participant, and the patient needs to be educated of what it is that you're doing.
Critically important. And, it's interesting because a lot of times you see that the patient takes a very proactive role. And, I'll give you an anecdote where I went to round on a patient, and it was around 5 or 6 in the afternoon, and the patient had just gotten into bed, and the patient said to me, "Oh my God, doctor, this is the first time I actually get into bed today. I've been walking all day.
Fantastic.
I have been out of bed
Wonderful.
more than 8 hours." But really, so you can tell that the patient sort of like takes pride in achieving some of those goals that we set for them.
Wonderful. Talk to me a little bit about how it is to take care of women, right? All your patients are women,
Yeah.
and women have other responsibilities.
Yeah.
Traditionally and also non-traditionally, a lot of times they have young kids.
Mm-hmm.
A lot of times they are tasked with taking care of their entire family, including all their parents. So, is it true that women want to get back really quickly, and how is it different than taking care of men?
Yeah, I think, certainly for me, I see it as a privilege, obviously, to take care of my patients. And of course, obviously, women, and the inspiration for my going into medicine was my mother as well. But I think, as you mentioned, it's critically important in that, women are at the core of the family, often at the core of their team. And it is important to keep that in mind, that many of the decisions that we make and many of the recommendations that we make are not only impacting that patient, but also that world around them. And, I think that it is critically important to assure that when we provide counseling, when we provide discussions on prevention, when we provide treatment recommendations, that this is really going to impact not just one individual, but a whole core of individuals that are really, really dependent on our patients.
Right. What I noticed, in my career is that usually, if female patients come, they make decision. And if a male patient comes, there's always a female, either friend or spouse or anyone, significant others, and she's making the decisions for him.
Yeah.
That's what I noticed. So it's interesting to see, if the female is the patient, how different the care is and who is making the decision and what is the repercussion of that decision.
Yeah, one thing that doesn't doesn't stop me from being impressed every day is that women are incredibly strong, and not just physically but also obviously mentally, and oftentimes one can see, particularly in oncology, the decisions that they're making. Even at a time of distress, even in a time where they're going through an incredibly difficult time, they're always thinking about, like, what is this going to be the implication on my children, the implication on my husband, the implication on my family. And, that to me is honestly incredibly admirable.
And this is part of quality of care, right? We always say the patient and their family are in the center of everything that we do. And the quality of care that we provide is really not only to the patient, but really to their entire family. So this is a very important concept to keep in mind.
Absolutely.
So, Dr. Ramirez, you are a prolific writer. And what is the most... I am just curious, what is your book that you're most proud of, or the article that you're most proud of? Anything that you can share with us?
Well, yeah, I think that for those who have kind of followed my professional career, they will not be surprised that, of course, the article or the work that I'm most proud of was a study that we embarked on in 2008, actually. And it was a prospective randomized study evaluating the surgical approach to patients with early cervical cancer. And really at that time, the question was whether minimally invasive surgery should be the standard of care for patients with early cervical cancer who needed to undergo a procedure called radical hysterectomy. And in fact, actually, we established this prospective randomized study, and it was a total of 631 patients, 14 centers around the world. So it was quite an undertaking. It was 10 years in a study, but the study showed that minimally invasive surgery was associated with 4 times higher risk of recurrence compared to the open approach, and worse overall survival. So this was obviously a shock to our field, and it came at a point where we actually obviously had to stop doing minimally invasive surgery in patients with early cervical cancer, and it immediately changed the National Comprehensive Cancer Network guidelines. It changed all the guidelines in our field throughout the world.
Wonderful.
So it was quite impacting, and of course that was the article that was published in the New England Journal of Medicine.
Wonderful. Wow. So you also host a podcast.
Yes.
So what, do you have any tips for me how to get better?
I think you've done a fantastic job. And of course, obviously, I always appreciate the time that the lead of the podcast puts into the preparation and reading about the topic and learning about those that they're interviewing. So I commend you, because I'm sure obviously you have so many things to do during the day, and to be here and raising awareness about these issues is really very important, and congratulations to you.
Thank you. So I'd like to ask you one last question that I usually ask all my guests here. What does quality mean for you?
I think quality is excellence in care. And I think that that's what we all aim to achieve. And that's what we all look for as patients. And I think it's really critically important that an institution sees quality as a top priority in their mission. So I'm really incredibly proud and very energized by seeing that there is such an effort to support high levels of quality in this institution as I build on these initiatives for our department, for our system, and hopefully for other specialties within the institution.
Wonderful. Thank you for being here today.
My pleasure.
And thank you for listening. Quality Time is part of Houston Methodist Leading Medicine series of physician-led podcasts. So that you never miss an episode, subscribe to Quality Time. New episodes will download to your podcast device. If you enjoyed our conversation today, please consider rating this episode and sharing it with your colleagues. I appreciate your support. Thank you. And until next time, I am always listening.